have a private practice. I have a private practice that I've grown since retiring from university life for the past 6 years. And that's called Michigan Ability Center Physical Medicine Rehabilitation. I have been in practice doing this kind of work, and specifically with people who have been injured with neurotrauma for over 35 years, which just means I'm really old. And I wanted to acknowledge Dr. Jay Nagle. Jay was chairman of the Department of Physical Medicine Rehabilitation at Wayne State when I was on faculty there. One of the brightest and most knowledgeable doctors who's done a ton of research in the domain of traumatic brain injury. And he allowed me to borrow some of the slides and talk to it. So I owe him thanks for what's happening here. And before we really get into things, 2 housekeeping items. One is, tomorrow is St. Pat's Day, so there's the wearing of the green, and some of us also play on the green. Second is that if you know me, you know there's always a joke. So it starts out that an Irishman goes into a pub. He lives in Ireland, and he asks the bartender to get out his best Irish whiskey. Bartender does as requested, and the man says, "Set me up 3 shot glasses and fill them all." Bartender does, and takes 1 shot, downs it, next, and the third, doesn't say a word, and leaves. The next day he comes in, orders the same, does the same, and leaves without speaking. So the bartender's curiosity is really up. Guy comes in the next day and orders again, and the bartender says, "Sir, would you mind sharing with me why you ordered 3 shots at once?" And the man says, "Oh, that's easy. I live here in Ireland still, but we 2 brothers live in America. We used to drink together, so this is my way of continuing that process." So bartender thought, well, that's strange, but okay. And so months pass, and this keeps happening every day. One day the man comes in, and he orders 2 shots. The bartender says, "Oh my goodness, did something happen to one of your brothers?" He says, "Oh no, I gave up drinking for Lent." Good response, sorry. All righty, and Dr. Kelly saying, "Keep your day job, dude." So I want to talk just briefly about how, what happens with brain injury, because it pertains to what I'm going to talk about medications. And DAI is diffuse axonal injury. Our brains are about, all of our brains, mind you, not just mine, are about the consistency of jello. And they're covered by the calvarium, the skull, very hard to cover. And so either sudden blow or sudden deceleration causes either direct trauma or shearing inside that cover and all through the brain. And there's a whole cascade of events that occur. I'm not going to talk today about acute management of brain injury. There are a number of things and ongoing studies on how to minimize secondary damage after trauma in the first hours and days from when a brain injury occurs. But I will talk about the post-acute phase, which is what all of us do, and things that are of pertinence there. Why do I want to talk to them? Most of the people sitting here will never prescribe any of these medications. So, other than I was asked to give a talk, the reason is that you are the front line. You see people day in, day out. I see them a short time in my office with months in between most of them. And so I am dependent upon your expertise, your knowledge, your observations as to what's going on with these folks. And that helps me to begin to sort out what, if any, medications I'm going to choose to prescribe for this individual. The other part of that is, once we implement something like that, I need you to all observe and give me feedback, or even better yet, objective data, measuring with standardized outcomes, to tell me if what I did had an impact. So it is very pertinent for you to have some awareness of what types of issues that occur in the subacute and chronic stages that can be addressed pharmacologically. So that's really my rationale for choosing this topic. This busy slide, this Jay Love busy slides, is really just to show this is an axon. That's those wires that interconnect between different parts of the brain. And they are cells, they have physiology, they function based on that physiology. There's flow up and down the axon, cytoplasmic flow. The membranes are a lot of times impermeable in health. But with trauma, there's a lot of things going on that then break that down. Suddenly, these little molecules that normally can't get in there get in, and it disrupts the entire function of the axon. And so that's, of course, why we see clinically many of the things we see. There are also a lot of neurotransmitters, depending on what part of the brain we're talking about, that are in their function and their ability to handle receptors to adapt to change are affected by the trauma. And this is sort of a not entirely true anymore, but it's true. It's a standard MRI of a brain or a CT of a brain isn't going to show you DAI, diffuse axonal injury. It's just not going to be there. There are specialized techniques now. I'm not here to give an advertisement for anyone in particular, but Dr. Randy Benson is a neurologist and a PhD scientist. He's in practice in Novi, but I refer to him specifically because he created an imaging technique called diffuse tensor imaging. He only has one of them here in this whole region. And so if I send people to him, I can have him image them and find out, do they have this issue? NeuroQuant is a quasi objective way of getting this. It quantifies brain mass, but it doesn't really individually show you in detail the type of thing we're talking about. And this is, to me, very telltale. I learned a lot from this slide. Where does DAI, where's the brain most vulnerable? In the midbrain. We're going to talk about issues of alertness and concentration and other issues that are mediated at that level as a starting point. So for whatever reason, just by anatomically, it seems to be more vulnerable. Same thing with the corpus callosum, which is still connected between the hemispheres. This is not a slide you want to have be yours. You can see this big hole here in the corpus callosum and over here in the temporal lobe in the white matter. That's diffuse axonal injury in a major way. I have seen worse images, but that one's pretty severe.
Is it from one of our imaging machines now?
No, that's a brain slice. That's a fixed post. Yeah. Postmortem. Yeah. In addition, because of again what we talked about, the consistency of brain matter, it gets bruised, it gets slammed against the skull, and there's bleeding, which is what a bruise is, bleeding into tissue. Blood in the brain is a noxious stimulus, and it causes conduction block of axon potentials in the axons, so things stop working because of that. And there again are certain areas tend to be more vulnerable. In the gyri, the convolutions, if we go back, all these convolutions, so all these sitting out here are more vulnerable. And more importantly, certain parts of the frontal lobe, executive function, behavioral issues, temporal lobe, memory, learning. So again, what do we see clinically? Fits with what we see anatomically. And it really is major damage to the cells. It involves crushing and disrupting the cell. The other thing blood does and just general edema is cause anoxia, lack of oxygen due to lack of blood flow to parts of the brain. Blood causes vasospasms, it shuts, closes blood vessels. And so another mechanism yet in this cascade of, oh my God, that is occurring amidst all of this. And that's the whole domain of acute treatment is a very fascinating topic. It's very complex. It's not what I do anymore. Once upon a time, I was involved. Though I very much admire those who really focus on that. But it does, for sure, add to the whole picture clinically. Why sometimes, too, you see people acutely, very acutely, who are awake and talk to you, and then a few days later, they're in a minimally responsive state. And again, just to, there's biochemical changes. I'm not going to go into detail with this, but it just changes the anatomy, the physiology, the adaptability of the brain. How do we learn? Well, how do we put down in memory? It's by making new connections between axons. Those axons have to be healthy, and they have to have the ability to do that in order for those things to occur. And it even includes, issues of the mitochondria, which are the energizers of every cell. I mean, it's just on and on and on, all the things going on. So let's get to what I really want to talk about today. There are several disorders of cognition that we see clinically. And I will right now say agitation. Some people will argue that they're right, is more behavioral than it is cognitive, but I'm going to throw out some thoughts on that as well. But we talked about that midbrain area and the consciousness level, conscious center is at the midbrain level. So people who are minimally responsive, they may open their eyes, they may move either purposely or non-purposely, but they can't speak to you, they can't interact. It's because of severe injury to that area. We'll talk about these other things in due process, but I'm going to start with talking about options for helping with arousal. So this talks about using them for 12 weeks or more. That's also kind of in the acute status too. But most of the time, when anybody here might be involved with somebody that's minimally responsive, that's going to probably be in an institution setting. So it is during that early period. So I kind of welched on my promise of talking about it, but this is specific because it I think can apply to more chronic situations as well. Amantadine is a very common old Parkinson's med. It's actually an antiviral, interestingly. I didn't know that. But it has anti-Parkinson's effect. Key thing is it increases dopamine. Dopamine's a big deal in so many situations, and particularly when it comes to this part of things, arousal. And interestingly, in a clinical trial, it did actually show that it got people to begin to respond sooner when it was administered. It was a big clinical trial, multi-center, double-blind placebo, et cetera, et cetera. So it does help. Other Parkinson's meds, we know that Parkinson's disease is a disease where the dopaminergic system is gradually deteriorating. But one of the first line meds that ever was created was Sinemet, which is levodopa combined with carbidopa. Levodopa is a precursor of dopamine. It's metabolized into dopamine. Carbidopa blocks up the reuptake of the dopamine, which keeps it around longer. It was found that if you only gave levodopa, it disappeared quickly. So that was the reason for making the combination. But interestingly, in a small clinical trial, at least, it did help wake people up. I don't know that I've seen it clinically used in my practice. I haven't, and I've never encountered it, but I found it very interesting because again, when we're looking for opportunities, we're looking for ways to try to move things forward. The other part of this I'm looking at is what are the side effects And while none of those sound wonderful, they aren't. And at the end of the day, it's a balancing act of risk versus benefit. Another Parkinson's med, bromocriptine, otherwise brand name long ago, was Parladel, another dopamine agonist. A retrospective study demonstrated efficacy for helping with minimally responsive state. There's a phenomenon I'm not going to talk about that often occurs in severely injured folks early on of dysautonomia, but it actually has value for treating in that situation as well. Stimulants, CNS stimulants, which actually, interestingly, have an ability to increase the presence of dopamine and or epinephrine by blocking reuptake. When we release neurotransmitters, there's a process to remove them too. So if we block that, they hang around long. And I think this is one of the things that really I thought was cool, was that it increased, data showed it improved cognitive processing, speed, and attention. It was thought it would help wake people up. Since CNS stimulant, why not? Turns out the clinical trials don't really bear that out. It really doesn't wake people up in most instances. There are case reports of magic where it's like throwing a switch and somebody wasn't responding, starts talking to you, but those are, again, case reports. Other stimulants, these Modalafil and Armodafinil, seem to wake people up again. They are used a lot in narcolepsy. And that can be a sleep disorder that is seen in brain injury. It's not common, but it does occur post TBI. So that's sort of interesting to me. What I do like about that is that the side effects are pretty minimal, pretty safe in relative comparison to some of the other options we have. So again, perhaps an opportunity. I don't know that it's fair to, again, to lump these two together, but the drugs are the same, so that's why I've done that much. So, attention and processing speed. Well, that's sort of a low-hanging fruit moment. I mean, children with ADD and ADHD have been given stimulants for 40 years or more. Methylphenidate being one of the first, out there. And again, we talked about two key neurotransmitters, dopamine and norepinephrine. And then Adderall, probably one of the most, if not the most single stimulant for attention that is given by at least PM&R docs, and I presume probably others as well. And again, has a positive effect on processing speed, concentration, and attention. So yeah, all of these again have side effects. My experience, for what that's worth, is both of those tend to be pretty well tolerated. It isn't common, I got to stop it because the side effects prevent them from continuing. And the other beauty of stimulants is, quickly, you start giving it, you're going to see if it's going to help, you're going to start seeing some changes almost immediately. As opposed to this one, atomoxetine, Strattera. Totally different mechanism of action. It prevents reuptake of norepinephrine. It does help with attention, but it's gradual. It takes weeks to really see its full effects. But it is an alternative. I mean, we have other reasons why stimulants may not be ideal. Some people become really agitated or anxious on them and can't continue. So we have a non-stimulant option to try. Unfortunately, no clinical trials, so it's really all anecdotal as to what the responses are. What about memory? Obviously, one of the biggies in brain injury. And acetylcholine pathways are key here, and I think this is one of the ones that always is sort of a pet peeve of mine, because I see so many other docs who don't normally do a lot with brain injury, prescribe drugs that have anticholinergic effects, a lot. And they're not doing it because they intend to cause harm, but at the end of the day, there may be other alternatives to avoid it, in many instances. And Aricept, everybody's probably heard of, started out for people with Alzheimer's. But there have been clinical trials in brain injury. It did demonstrate improved memory and attention in a couple of clinical trials. And then not really all that bad of a profile for side effects. The usual one is GI, but that doesn't come up all that often. It's once a day, it's easy. I've never seen this one used. It's out there, similar effects, but I've never seen it actually prescribed for brain injury. And Namenda, Becky Henley's favorite drug. She's not here right now to defend herself. Every time I forget something, she'll say Namenda. So, very, different toll. Oops. Don't touch the screens, dude. What do you call it? Anyway, different receptors, different neurotransmitters, but it does seem to help facilitate memory. And again, no GBI trials. So it's sort of, I guess, in a way, off-label to use it, but we, many times we'll try one medication, we don't get the response we want. Well, I'm not going to go with something that necessarily has the same mechanism of action. If I try one that has a different mechanism of action, maybe that one will have an impact.
I have a question for you.
Yeah.
Just as like an opinion, because I used to always ask for like Aricept for clients, and in your opinion, why is that not supported? Or do people shy away from it?
I think that the belief system, and I tried to find data to support this. Actually, Jay Maythaler's one that threw this out here, and I can't find data to support it, is that it's only effective early in the first 6 months, and it isn't effective very much after that.
Don't they say the same thing for like Alzheimer's, which is
Yeah, I mean,
that it's effective until it's not? I mean, it's
well, exactly. But the difference there is we're talking about progressive disease in the wrong direction
versus acute.
versus brain injury, which if we're within the first 18 months to 2 years, we're hoping to get some positive changes. I mean, just an aside there is probably ballpark estimate of when the most recovery is in the first 6 months, and that can be up to 80%. So early is really important. However, there is opportunity beyond that. And I mean, more where I'd say that I'm most skeptical is that somebody comes to me that's 5, 6, 20 years out, and whether this is really going to do much for them. On the other hand, it's fairly benign. I'm not risking much by giving it to them, and basically at the end of the day, if we try it for a while, it doesn't work, we just stop. Amantadine comes up again for executive function. One of the coolest parts of this particular study that I'm quoting here, improved glucose metabolism in frontal lobes. What does that mean? Well, glucose is the energy that drives brain cells. But the brain's more active. And clinically, it did show improvements. Now, executive function has a lot of different aspects, and I'm not defining it for you right now, nor do I really have time, and that's a different discussion. But that being said, I have yet to encounter in my clinical practice and with other docs who are doing this, for them to specifically prescribe amantadine to try to address executive function impairments. And again, the side effect profile is pretty minimal. So why aren't we doing this? And interestingly, if you combine it with Cinemet, you get even better results, according to one study. So it must be something slightly different in their impact on dopaminergic pathways to have that effect. Now, I haven't seen anything that's individual with Cinemet for this particular application, but nonetheless. And again, bromocriptine, pretty innocuous drug. It doesn't have a lot of side effects. And in low doses particularly, it's supposed to be potentially beneficial. So do we develop a cocktail? Obviously, you don't start with all three. However, there is a systematic way of approaching this, but I will talk at the end about how critical it's going to be for best outcomes. That there's a lot of communication between team members and sharing of data over time in order to really know where we are. Agitation. Well, there's a lot of different aspects and definitions of agitation. Most often what I'm dealing with is what I would call short fuse syndrome. Basically, things that historically would not have set the person off. Some small trigger really sets them off. That's damaging. It's damaging in families, particularly. I mean, I think this is one of the things that is hardest for family members to understand and most stressful for them all. And one of the reasons that it puts relationships at risk. So what our first line drug for that is actually what was a blood pressure drug, propranolol. And it is non-selective as beta blocker. There are beta 1 and beta 2 receptors. Beta 2 really are more important for blood pressure management. But what's cool about propranolol is it gets through the blood-brain barrier. What do I mean by blood-brain barrier? In order to get into the brain tissue, it has to get out of the blood vessels. And the space between the cells in brain blood vessels are very, very small. So it has to be molecules small enough to get through those openings. And propranolol does. Jay Maythall, I like to call it a dirty drug. What does it mean? Well, it does so much, does so many different things. And, you know, take a look here as it can help with headaches. It's prophylaxis for headaches. We'll talk about that. It's helpful for anxiety. Medical students, I wasn't one of them, learned early on when it came out that if you had a really tough exam, it helped you stay calm. So it's not uncommon for them to somehow come by that.
You moved your screen.
Yeah, I think you skipped the ad one.
Stop it.
You're talking about the Inderal.
Yeah, Inderal is branded. And what I like about it as well is it comes in a long acting. And clinically, you know, standard formulation is 3 times a day. I don't know about you, but I can't take drugs 3 times a day, let alone somebody in this situation. Long acting is once a day. And it seems to be effective. And compliance is much better and more consistent, you know, with a once a day medication like that. And it talks about these side effects. You know, one of the beta blockers, lower blood pressure, they lower heart rate. If you're talking about high-end exercise, that could get your way. But most of our clients aren't doing Olympic level training. And it doesn't seem to interfere with normal therapy. Orthostasis, you know, again, you know, postural, I've yet to see that in a clinical setting with the people I've prescribed it for, but you know, it's reported, so I'll talk about it. I mentioned that autonomic dysregulation where the whole autonomic nervous system goes nuts after severe trauma. It's another drug that's used along with bromocriptine to manage that, but that's early. Indolol, I have again never seen it prescribed or used it, but it appears that sort of held back and reserved for really extreme cases for violent people that get into physical altercations, where propranolol may not have enough ability to manage, but it can. So I found that curious. That's not common, fortunately, at least in my practice. I've got a handful of people who have been in those kinds of situations. But I think many of you can think about situations where you work with clients that were at risk for it, that if they went out in the community, they might get themselves in harm's way to their behavior. Found curious at trazodone. It's a tetracyclic antidepressant. We'll talk about some of its other uses within brain injury. But one article, you know, and cited a small study of inpatients that it was a drug of choice for early agitation on an inpatient unit. When I was in training, benzos were the thing. I mean, you just grab the Ativan shot, 4 milligrams, they were out. Turns out, however, I'll explain that in a moment, that's not a good thing. And it has other potential impact. So here's something that can be mildly sedating and not knock them out. And same thing with we talk about other standard neuroleptics, because those got used a lot too, like Calvin. But that's a pretty safe bet, just to kind of take them down and still have them be able to participate.
What is the side effect? Sorry, I hate to admit this, but I can't say it's a prior. What is that? I'm not a nurse. Are you gonna tell me?
I'm gonna tell you, yes, it is. It's only males, and it is an erection control.
Of course I would ask that.
That's why I answered this.
Step back. Step
So,
back.
the good news is, I almost thought you'd get your peripheral brain out there. So, but the good news is they will never roll out of bed.
No. That is the term for that, so I learned something.
Well, that's why I didn't spell it.
I think it's the best question of the night.
Have another glass of wine.
I think it's a question.
All right, so valproate, Depakote, and it's got there's divalproex, but they are really interchangeable. Common anticonvulsant. Earlier on in management of seizures post TBI, that was one of the mainstays. But interestingly, because it was found in mood stabilizers, it's used in bipolar illness, and but also in agitation, is highly effective. Why isn't it used kind of? Because people don't like the weight gain, and it puts a lot of weight on.
And
It's not,
Steve's teeth was bad too, does it?
no, that's actually more
Oh, okay, I was thinking it was
yeah,
Depakote.
phenytoin. Phenytoin actually causes thickening of the gums. It's really hard and really distressing to people.
Way worse than prior. Wait.
But most of the time more visible.
Jokes for the
Can't carry your purse in front of your mouth. Sorry. Don't you kill it and I will stop.
The other part of it is that the people don't like having to frequently, about every 3 months, get blood drawn for liver functions. That being said, one of the things as a physician that I really look for is what I call keepers, 2 for 1. Can I take care of 2 issues with 1 medication? And valproate offers that opportunity. But I would it's more again trying to work with the individual, and if it becomes too upsetting to deal with some of the side issues, I have to move on. Tegretol, been around a long time. Carbamazepine. Again, very good mood stabilizer. Also has been used for seizure prophylaxis, TBI. It's thought to have greater negative impact on cognition. I don't know if there's firm data supporting that. It is effective for helping with agitation. The reason docs tend to stay away from it is this: it can actually suppress the bone marrow.
That's, yeah. You gotta leave a big. Yes.
Oops.
Double tap it. Double tap.
Yes.
Very.
All right, can I scroll down? Yes, that works. All right. So it's, to me, again, this is a kind of a situation where you have to weigh risk versus benefit as to which you choose.
Oh, I can't.
Double tap that.
Double tap it. Now do it. Here you go.
There.
I feel like the active clapper. All right. Atypical neuroleptics. Hopefully some of these names are somewhat familiar to you. Again, we try not to go here. They have more side effects, but probably the most common one prescribed is Zyprexa. And I'm not sure why. It's actually has probably some of them several side effects, although people seem to tolerate it well too. Quetiapine or Seroquel is commonly used. It tends to make people very sleepy, so that they administer at bedtime, so it can be a sleep aid at the same time. So sometimes that's useful. I've never seen Geodon or really used in this setting. I have seen Risperidone used, and I've seen some good outcomes with it. So any of these are potential options if those more first-line medicines aren't helping enough. So that's really where these fit into the story, but no clinical trials for anything. So we're flying by the seat of our pants.
I was always told that the Geodon takes quite a while to work, so a lot of times they'll add it to a Risperidone. Is that what you've seen?
I honestly I have not worked with it. So
Our older,
Yeah.
long-term TDIs,
Okay.
see them like on a Geodon
Mhm.
and
Okay. I mean, I could see that. I mean, that's probably, I'm guessing that may have more come from psychiatry from PMNR. I don't know.
I don't know.
Because those
to be
guys
honest.
usually use these medications far more frequently than I do.
What did you see the side effects of the Risperidone?
Sedation, restlessness, and metabolic.
Out of all of them, I think the one that I see the most is definitely the Risperidone. It's like that seems to be.
Well, it gets used, you're gonna see names come back, over and over with different situations here. Coming back to kind of that twofer thing, or, what's most benign to try. And Trazodone is really pretty safe. Doesn't always work, but at least it's safe. I think you can read that without. So this to me is also important. Now we're talking again about how that first 6 months is when the greatest changes occur, and I think this is really where this is most important. But haloperidol, Haldol, actually prevented recovery permanently in early group. That really upsets me because I have seen it administered, and particularly back when I was treating it. I still see it used. We've got so many other choices. And it's sort of a dilemma. I mean, I saw someone yesterday whose psychiatrist has them on Haldol. They also have them on amitriptyline. We'll talk about we'll talk about how acetylcholine is so important for memory and learning. So she's getting a double whammy. However, she's doing okay, and she's 15 years out. So I have to kind of weigh, okay, do I take the risk of changing things and having her really dysregulated for a period when she's really doing well right now. And so I let it go for now. But to me, that should be a choice only after other things. The other thing about these is the extrapyramidal side, tardive dyskinesia, lip smacking, hand movements, things like that are very distressing to people and not very treatable, and they're permanent. So if you take it long enough, those things are going to evolve.
With some of the DNA testing, that identifies if you're more susceptible to it.
It's an interesting question. I mean, I started to work with that a little bit, but I didn't really find it, that as predictive as I hoped it would be. So I haven't really gotten back to trying that, but it's an interesting question, and maybe it's improved.
It's improved in the last few years.
Yeah.
We used it a few years ago and then we just started.
Yeah, I mean, that's what I was trying to get about. Wasn't that terribly impressed, but maybe they got it down.
Do you use a gene scene? That company?
No, we use lab genomics from out of California.
Sleep disturbance. High percentage, one of the highest percentage of issues on the brain. And this is endogenous, meaning it's because of brain changes. And so, I mean, that to me is key, because sleep is important for recovery. Sleep is important for not having people be agitated. So one of the things we have to sort out in the scheme of symptoms we're dealing with is because they're agitated, it's because they've got this endogenous sleep problem. Are they depressed? We'll talk about depression in a minute. Are they in pain? I mean, there's a number of reasons why there can be sleep issues. So, and I mean, there's specific ones that we see subclinically, kind of specifics. Excessive daytime sleep. A lot of our people, particularly early on, sleep during the day 2, 3, 4 hours at a time. I've always wondered, is that really a bad thing, or do they think that sleep is part of their recovery? I don't know, but it could be dysfunctional, obviously. So that's, and narcolepsy, as I mentioned, is uncommon, but that's just basically you're busy talking or doing something, you're out. In sleep-related breathing disorders, I mean, people very often we are sleep tested because there is that possibility. And part of brainstem function is the respiratory drive. So is that part of why we see this? I don't know, but I certainly think that's one possibility for something like a sleep apnea, particularly somebody who's not overweight. So that tends to be just because the airway getting closed off from the extra weight. But this one I think is really interesting. A study looked in 2016 found that people during their sleeping hours with brain injury produce 42% less melatonin naturally. That's to me really something.
Is it just traumatic or is it also for?
It was only studied on traumatic. It could entirely possible it could occur in acquired as well. Non-traumatic brain injury. But so what do we do about it? Well, we come back to our buddy trazodone. And trazodone in lower doses, meaning 100, typically 100 milligrams or less, sometimes up to 150, typically not higher, has an impact on key receptors in the brainstem that help induce somnolence. So it's a hypnotic, but it's a mild one. People don't wake up hungover most of the time. And in a pretty high percentage of folks gets affected. Not for everyone. We do have failures. Often we'll start with melatonin, particularly if they don't want to even go here yet. For obvious reasons, what I just told you about the melatonin. How much of that actually gets absorbed into the brain, I don't know that I've ever seen data on that. But it's benign again. You give it's not going to hurt them. Anywhere from 3 to 20 milligrams a night. We start at 3 and work our way up. See if we get an effect. Interesting one is Ramelteon. I have not seen that used. It's another tetracycline. But I think one of the reasons it's not is look at the side effects: depression, hallucination, sleepwalking, hypogonadism. Who the hell wants anything?
Sleepwalking.
So it's out there. It could be a substitute. I mean, for a failure of a trazodone, to try it. I don't know. I had to really think about it long and hard. I've always heard that the sleep aids are kind of bad things to do for people with TBI, but I learned a little something. What I learned is that the newer selective ones only bind to GABA A receptors. Diazepam, all the benzos bind it GABA A and B. And for that reason, they are shorter acting. And they tend to have, again, less carryover effect into the next day. So these two are probably, Ambien and Lunesta, are two of the more common ones if trazodone doesn't work. I start with trazodone, I'll start with melatonin, sometimes the two together. And if we're still not where we need to be, then we'll talk about those two. And mirtazapine, interestingly, as we talked about earlier, is a tetracyclic, but it has a lot of side effects that, again, scare me, particularly suicidality. Somehow that just doesn't appeal. It's just as scary. And weight gain. But coming back to what I've seen done, benzodiazepines, the Valiums, the Ativans, the Xanaxes, Klonopins. I've seen a lot of psychiatrists prescribing this stuff.
Still.
Yes, still. And at least in animal studies, it interfered with neurological pathway recovery. Hasn't been shown in humans, but so that's enough to make me worry. But we do know there is hard data that definitely interferes with cognition. It interferes with normal sleep patterns, and there is hangover a lot of times during the day, and it messes with memory, and poor memory. To put it the way one of my pharmacology professors in medical school, booze in a pill form. Might as well just have a glass of wine. I mean, in all seriousness, it's Librium in an acute care setting. Somebody's going through delirium tremens, withdrawal from alcohol. That's what's given, and it stops the symptoms. Works perfectly.
It gives Xanax withdrawal of alcohol.
I'm sorry?
Did you say you were given Xanax or?
Not Xanax, but one I didn't put up here. Librium.
That liver, that's what.
Yeah.
Thank you.
No, but I mean, the other part of that is Xanax in particular. If people are on it a long time, it stopped suddenly. I've seen seizures. So, not a benign drug. But also anticholinergics, I mentioned that earlier. Tricyclic antidepressants. And they were the first line of antidepressants before the newer generation we'll talk about in a moment came out. They're still out there. They still have applications. However, because of the key importance of acetylcholine and those pathways in the hippocampus and temporal lobes, et cetera, it's going to have a negative impact on people's memory and learning. And so, the one that sort of gets forgotten about are bladder. Many people have hyperactive bladder in the brain, and they're taking an anticholinergic medication because it inhibits bladder contractions. Well, there are a couple of options out there now that are not anticholinergic in their mechanism of action, so you don't have to go there. So why do it? But this one is, I think, the one that scares TBI docs the most. Is a low seizure threshold. But I see amitriptyline, I see nortriptyline. I mean, it just in doses that
A lot.
yeah. And, so I'm just kind of cautioning folks. It's not a battle necessarily you all want to take on yourself, but sometimes when we're getting new people in and we're doing intake, we're trying to assess what's going on. It might be cause for discussion of how do we deal with this. So, depression, another very high frequency. And I've seen as high as 70% in studies, but guesstimate is somewhere a third to half. It's a lot. More importantly, in this one study that reported 42%, 15 years later, 1% of them had committed suicide. And that's just so sad to me. Potentially preventable, at least in some instances. The other part of it is that depression and anxiety very often go together. And so, as we talk about medications, we're also going to talk about, do we co-treat those concurrently or not? Zoloft, TBI doctor's favorite antidepressant. Why is that? It has the highest dopamine. We're talking about how wonderful dopamine is. And it seems to, improve cognition on top of dealing with depression. It's a serotonin reuptake inhibitor. Serotonins are happy neurotransmitter. And so it prevents it from being broken down. Very effective in an 8-week clinical trial for people as far out as 2 years. Now, I have people who've been on it for multi-years. And the upside is there doesn't seem to be any long-term health issues. I think most of these things, the nausea, diarrhea, tremor, et cetera, aren't hard story. This, however, decreased libido is, and that bothers them. I don't blame them. It really does take your desire away in many instances. It's one of the downsides of the SSRIs. And these two both have anti-age impact as well as serotonin. So there are alternatives that are good alternatives. And at the same time, they are not without their own particular concerns. QT prolongation causes cardiac arrhythmias, and the escitalopram, the two citalopram and escitalopram are very similar. Only real difference is in the chemistry days are what are called enantiomers. Citalopram has both levo and dextro, so mirror images of this is, I believe, just levo. So it's you dose it in half of what you citalopram. That's your cocktail factory. But they're both. I've seen them both work well. The reason these are liked so well over their earlier predecessors of fluoxetine, which is Prozac, or paroxetine, which is Paxil, is less side effects, and these are more rapid and onset. So they have gained favor over. And then there are combos, serotonin and norepinephrine reuptake inhibitors, SNRIs. Duloxetine is one we commonly prescribe. This is again a super deal. Why? Because it is effective for neuropathic pain. It's FDA approved for neuropathic pain. Now that's from diabetics, but it seems to work in other instances. So, and we do have people from their neurotrauma or peripheral trauma who have issues with neuropathy. So if they're not really overwhelmed with anxiety, that's a very common one used as an alternative. And venlafaxine doesn't have clinical trials to back it either, but it's a good alternative. They're pretty similar in their mechanisms of action and what they do for folks. I think one of the most interesting ones to me, I always feared bupropion, Wellbutrin. And it was because of this right here, lowered seizure thresholds. And I've never been very hesitant to prescribe it. But what is curious to me is this increases alertness and in attention. 2 per time. Somebody's depressed. They're either not tolerating stimulant or not responding to it. Maybe we can get some extra mileage with that, treat depression and their attention and concentration concurrently. And it was interesting. One reference I read actually said, again, underutilized opportunity. We should pay more attention to this medication. So. Good old Buspar works on serotonin pathways. Good anxiolytic, actually. Sort of, people go for the benzos first. In fact, you can. Well, now you see.
Like that. Yeah.
So, I mean, you can dose it. Some people dose it 3 times a day. Some people dose it 2 times a day. But there's a large bandwidth of what you can give safely without a lot of side effects. And, it sort of is the chicken before the egg or the egg before the chicken when it comes to depression and anxiety. Are they depressed and anxious, therefore anxious because they're not getting anything done or can't accomplish anything? Or are they anxious, which makes them depressed? And that's never easy to tease out. But and again, it talked about all these wonderful side effects. Back, cowboy. Things like chest pain, pounding, heartbeat, discoordination, rash, sore throat, muscle weakness, ever. So, I mean, I really think it's one of the safer drugs we can give. It's not habit forming in any shape or form. They can be weaned off of it readily. A lot of psychiatrists actually use it as an adjunct to SSRIs or SNRIs in combination. Very common for them to do that. And there was always this fear of serotonin storm. You get too much serotonin, things go haywire. More recent research has said it really doesn't exist. So it's not an issue. Benzos for anxiety. We talked about the effect on cognition, but you've known some sad drunks. Well, you have sad benzo people because it can worsen depression. And as we talked about already, it has other negative effects. So really to be avoided unless they are so overwhelmed and dysfunctional and nothing else to work. All right, we're on the home stretch. We're doing on time. But neurological issues, of which there are many. I'm only going to cover some. I mean, this is there's a whole domain of more mental health management issues. Some of the same medicines are used in that, but I mean, I really, in those more extreme situations, I'm referring to asking psychiatrists to weigh in on the story. So you get what I do. Alrighty, so seizures. Post-traumatic seizures are not that frequent. Probably 10% of the population. Most common in penetrating wounds. So gunshot wounds, heart skull fractures, stuff like that. Is where there's more direct trauma to the brain. And then those I know those people have worked a lot with people with brain injury disorders of initiation. You can wind them up and point them in the right direction and guide them in a treatment center, and they perform. Put them out in the real world, nothing happens. And that's a manifestation of the brain injury, obviously. But what do you do about it? Because ideally, you want them back in the real world. Movement disorders, we'll talk a bit about that. Fatigue, neurofatigue, just perception of being fatigued. And what do you do about that? Spasticity and rigidity, obviously, and more severe motor cortex injuries or motor pathways, subcortic. And post-traumatic headaches, another one that seems to be of high frequency. Post-traumatic seizures, levetiracetam, Keppra has become the go-to. We talked about why people don't like Dilantin because of its side effects. It also seemed to have a greater impact on cognition, negative impact on cognition. And it's clearly, when compared to Dilantin, which was kind of the gold standard before it came out, it was comparable in its efficacy in preventing seizures. Some people actually use it with lots of appetite. They're trying to lose weight. It's not a kind of off-label for it because sometimes get prescribed for that. The one that I wasn't aware of, to be honest, was decreased bone mineral density. Our people who have impairment of motor function, and particularly full paralysis, lose bone density. We know that. So here we are with a drug that is commonly prescribed in a subpopulation that can contribute to that. So that's an important one to pay attention to and follow up on. Lamictal, it affects reuptake of both serotonin and norepinephrine, and it's actually in essence an antidepressant. but it also has seizure. And it's commonly prescribed now. Carbamazepine, Tegretol. When I was in training, there was a period of time we thought it was a better drug than Dilan. But the studies actually showed it had similar effects on cognition. And as we talked about, the bone marrow suppression is pretty scary. You got to monitor that frequently and make sure you're not doing something really bad with somebody. On the other hand, as we said, it's a mood stabilizer, and you can get 2%. Disorders of initiation, very high. Have some form of it. It may not be severe, but it's there. And as I mentioned, putting them in a structured environment, which we do out of necessity and for therapeutic settings. You know, some part of the treatment plan, presuming they're making progress and getting to a point where they can, is to try to start to move them out that setting into other situations that are more or less supervised, less structured. Other issues that can make them look this way. There is a post-traumatic hydrocephalus from scarring ventricles, you know, and then expansion of the ventricles, you know, at CSF and put internal pressure on the brain. And certainly that can cause them to look like they're not responding to and initiating. But it's part of, again, doing it, you know, very often these folks come to us, they've been initially for a lawsuit, but if it's a change, that's a key in my book. If somebody comes to me and they've been a certain way, start seeing a negative change, that's a threshold for me to see it's time to report. Neuroendocrine disorders. We make a lot of referrals to, and we have one endocrinologist in particular, Dr. House Haley, who is in Southfield, who is very, very well versed in neuroendocrine changes found in brain injury. I wish we had more like that. Because I think, honestly, this contributes to a lot of the other behavioral and functional issues, more so than we are aware. But again, kind of sorting out why are we seeing what we're seeing, and of course, mood disorders like depression. People that are depressed, we know don't actually. So what do we use? Ritalin, Adderall. Actually, interestingly, amantadine and bromocriptine, those two anti-Parkinson's meds that also improve executive function, seem to sometimes help get them moving. And again, I think in some instances you could do a combo of a stimulant and anti-Parkinson's if you want to be that well, just one. Tremor has a higher frequency than I knew, 20% approximately. But thankfully, and one of the things that propranolol can do for us, that wonderful beta blocker, non-specific, dirty drug of Dr. Nicholas, will often help with that and with minimal side effects. I have seen Parkinsonism, it's pretty uncommon, but you basically treat it as if it is Parkinson's disease, even though it's secondary to the negative changes from the trauma that involve the dopaminergic pathways. Fatigue. More talking here, I think, about mental fatigue and physical fatigue. They're really different animals, and we put people a lot of times through a lot of physical training, and sure, they're going to fatigue if you're pushing them physically, and that's okay. It's actually desirable. You don't gain strength without reaching it, so that's actually important to achieve. But again, kind of coming back to what are we really dealing with? You know, is it depression, sleep disturbers? You know, if I'm sleep deprived, I ain't got no ability to do a whole lot of energy. And again, the neuroendocrine problems, particularly, you know, about thyroid and that from metabolism. So what do we do? Same, you know, a couple of the same guys that we've been talking about, plus amantadine. So either, you know, Ritalin, Adderall, or amantadine. If you're going to do anything, it depends on how much it's getting. And the good news is that very often, people who are in recovery, you see them kind of transition out of that. So sometimes doing nothing is okay. Spasticity, this gets talked about a lot in a lot of other circles and a lot of different diagnoses. Baclofen, biggest, again, first of all, on spasticity, we only treat it if it's interfering with function, positioning, or causing discomfort, or keeping them awake. It's got to cause a clinical problem. It's meaningful. The presence of spasms and spasticity of itself doesn't mean automatically get medications. There are other measures we can use, heat, cold, stretching, that are non-pharmacologic help. And the biggest thing about Vaclin, you could give, there, to my knowledge, there's no toxicity with that. You could give them enormous amount, they're going to fall asleep. Just makes them stay. But I don't recommend that. But at the same time, the other issue with Baclofen in some studies is that somebody who is using their tone to support themselves to be upright, if you take too much of that tone away, they are not going to be mobile. So there's a bit of a balancing act with that as well. So the people from Walk Line shaking their heads, we've dealt with that a lot there. Particularly more of a population of spinal cord injury, but it can certainly be in this population as well. Tizanidine, different mechanism of action. Baclofen works at the spinal cord level only to inhibit reflex responses, both monosynaptic and polysynaptic. It's of interest to you, but tizanidine works both in brain and spinal. And it's interesting is that it seemed to have more effect on flexion muscles. I can't tell you the neuroanatomical correlate what that study, but there was an observation. So, flexion muscle torsion or lower limb too. Hypertension is probably the biggest issue. Somnolence is also a big one. But it's a cousin of clonidine. It's a weaker antihypertensive, but it has that effect. And clonidine used to be used for spasticity, but it's a strong antihypertensive. And in some of our folks, they already have a baseline blood pressure that's on the low side. So, doesn't work to bottom them out. One of the ones that's underutilized, again, in my book, particularly more severe situations where you're dealing with rigidity. What is rigidity? What's the difference between spasticity and rigidity? Anybody want to take a shot at that, or can make me do it? Spasticity is a rate-dependent phenomenon. It's elicited by a quick movement or stretch of the muscle. So if I have a spastic biceps and extend my elbow rapidly, it contracts back. It produces contraction of the muscle. Or certain cutaneous stimuli, like brush the muscle, it may contract back. So it's not there all the time. Rigidity is. It's constant contraction of muscles, often on both sides of the joint, so you can't even move the joint. Literally rigid. The two are not the same, but our bag of tricks is small. So we use what we have here for the most part. What's particularly, I think, helpful with Dantrium is really severe involved people with chronic trauma who have more a rigidity issue. Dantrium doesn't affect sensorium. It works at the muscle level. It actually blocks the whole excitation, contraction, coupling process in the muscle fibers to reduce muscle tone, but it does not make them sleep. Like the others, you can also take away too much muscle function. And the reason that people avoid it is the hepatotoxicity. But what I don't think is widely known is if you monitor liver enzymes, particularly early on, for say the first 6 months, and they're not going up, odds are not going to go. I mean, you still check them periodically just because. And it's only about 1 in 1,000 that even have a bump in their liver enzymes. So the other 999 are fine. So, I mean, that's not a huge risk, ratio to me versus potential benefit for something that isn't going to mess with their head, which the other two will. other options outside of oral medications. Penile nerve blocks are kind of a thing of the past. Penile is a nerve sclerosing agent. I did a lot of these early in my career before there was a Botox. A lot of the people I worked with their extensor tone in their lower limbs would have hip adductitis. They couldn't get the legs apart for hygiene or bathroom or for a base of support for stance. So we could get to the obturator nerve in the groin, and we do a temporary block with Marcaine, which is a long-acting local anesthetic that give at least 8 hours to see if it worked well. If it did, we came back at another appointment and injected 1 or 2% penile solution, and that would last 10 to 14 months before there was nerve regeneration. It's effective. Why don't we do it still? It's non-selective, not to all. If it's a sensory nerve, they were done on tibial nerves. Well, tibial nerve has a lot of sensory fibers, and so we would do that for calf muscle spasticity. But the last one I did was the last one for a reason, because it was a fellow with a brain injury, and he was nonverbal, but he could communicate. And he came back a week later, and if you sclerose sensory nerves, you can get a bad dysesthesia. And that's the only time I was ever given international sign of peace and goodwill for something like that. And I understood it. I wasn't angry, but he was in a lot of it. So Botox is I think it's less pervasive in terms of how much you can affect. You're limited to how much botulinum toxin you can inject at any one time, because the body will develop antibodies if you give too much. And one of the problems with repeat injections is that still and then you can't have it. But there's Botox A, botulinum toxin A and B. B is more likely to evoke an immune response. So we start with A, but there is a backup. But the beauty is it doesn't affect the muscle completely. You can selectively give less units, so the muscle still functions some, but the tone's reduced. The blockade is at neuromuscular junction. So acetylcholine gets involved here as it's released and attaches to the receptors on the muscle, which is what starts the contraction. Well, it binds to the receptors on the muscle, acetylcholine receptors, permanently. The reason it doesn't last more than 3 months or so is because we're very good at making receptors. So the permanent block of the receptors only lasts so long. But no sensory side effects, dysesthesia, et cetera. And done in an office setting as well. In more extreme situations, again, we don't do this very often. In fact, we don't do it very often. Period. You treat people back. You baclofen instilled by a pump into the cerebral spinal fluid, typically in the lumbar spine area. When we're talking micrograms as opposed to milligrams, can be highly effective in very complex situations. And the pumps are programmable, so depending on what the person's routine or needs are at a given time of day, you can adjust the dosing accordingly. They have potential complications. Sometimes catheters get clogged, pumps fail, although not very often anymore. The initial ones fail off. Battery life's decent at 7 years, so it doesn't have to get it. Refilling it is actually done through injection into the units that's right beneath the skin, subcute. So it's not wonderful, but it's not awful. But so I mean, it is an option. Again, in an extreme situation where somebody's home, particularly rigidity again, but sometimes spasticity where they just jump all the time, and then the oral meds are done. It can be a solution. Last topic. Post-traumatic headaches. Again, a high frequency event. In many instances, it improves over time early after injury, but some people have it persist for a long time. So, there's a difference in the ICD-10 codes for intractable versus non-intractable, meaning intractable is it's debilitating, it's there all the time. Most of the people we see are not in there. They have intermittent headaches. It can be several times a day or at least several times a week. It can last anywhere from a few minutes to hours. But anybody who's ever particularly had a migraine headache for any period of time knows how miserable it is. And this is not the same as a migraine, but we kind of treat it some migraine. That's the best we got. So first line are just non-steroidal medications. And I think the most interesting one that it's expensive, so it doesn't get prescribed very much, is Cambia, diclofenac, but in a powder form. But somehow or other, having it in powder form, except instead of a compressed tablet or a capsule, releases it better. And it is probably one of the most effective treatments for post-traumatic headache. And again, side effect profile is nothing different than any of the other non-steroidals. None.
I have a question for you, because I was prescribed Cambia for migraines, and it's phenomenal for a migraine and it's quick.
Right.
But why would like my face just would kind of go numb? Is that like a side effect to the migraine, or is that?
That's to me. Migraines tend to be vascular,
Mhm.
and I would say that that's more just
Part of
vasoconstriction causing you just enough
Mhm.
not true anoxia, but decreased blood flow to that. So no, there's nothing about NSAIDs that should ever cause that. But, again, in less severe situations, we're using these abortives, meaning that you wait till the onset of headache. Don't take medicine to prevent it or take medicine all the time. So that's how these are used. And the triptans have been around a long time, all three of those. I prescribe rizatriptan quite a bit. It seems well tolerated. However, the beauty of these two is, look, rizatriptan is oral only. These two have a nasal spray or subcutaneous injection. We have people who have dysfunction cancer. And those are, a nasal spray and or subcutaneous injection work very quickly too. So they are good options. And there are people I work with who are on either. Fioricet's an older drug again too. Combination of barbiturate, acetaminophen, and caffeine. Caffeine seems to be a useful drug in vascular headaches. Causes vasoconstriction, decreases the distension and pain. So I drink lots of coffee. But it works in many instances. I mean, it's kind of one of those that I'll probably go to. This will be in place as long as there's no contraindication. Older folks with hypertension or diabetes, you'll kill their kidneys with these. But if they can't take these, they'll start somewhere down here. And if that doesn't work, try Fioricet too. And, the downside of the triptans and Fioricet is, guess what they can do? They can give you headaches, rebound headaches. If you take too much of it too fast, it actually has a paradoxical effect. So we typically limit dosing to well more than 3 times a day. And I've even caught heat from pharmacists now about headache frequency. Newer ones. These are not, these have only been out for a few years. And I don't know that I've seen anybody with a lot of people with migraines say these are superior to the triptans. They have a very different mechanism of action. Calcitonin is a hormone. Has an effect on bone metabolism. How that relates to headaches. Some research to figure that one out. So and they're getting some pretty substantial reviews. So I think I forgot to do one more slide. No, oh, yes, maybe I didn't, but. All right, so beta blockers we talked about previously. Propranolol is mostly what I prescribe, just because there's usually some other, concurrent symptoms that Tylenol will help with. But if you really were just dealing with headaches, metoprolol, which is just a beta 2 receptor blocker, not both beta 1 and 2 like propranolol, and is frequently prescribed for blood pressure, can also help in this instance. So we talked about valproate can be helpful. It has the side effects, particularly the weight gain, is not okay. I do use topiramate, another anticonvulsant, as a prophylactic, and it seems to work pretty well. Dose twice a day. Doesn't seem to have a bad side effect profile, and often is effective as a preventative. Botox, interesting. I've always wondered when I started hearing about neurologists and TMR docs giving Botox injections, I think people swear they help. And I'm not going to argue with success, particularly when they're refractory to other. So I have situations where I refer them out just specifically for that, because I don't do them myself, but I'm not afraid to do that. And they look younger. And it's, what I forgot to put up here are the injectables, the Ajovys, and there are 4 of them out now. I remember all their names off the top of my head. We've had some pretty good results with that too. Once a month injections, maybe self-administer, or if they're not, don't have hand function, somebody else can easily do that for the family. Very often they are helpful. Again, it tends to be kind of a pyramid of things. We try the abortives if they're not too bad to begin with, add the prophylactics, and if any, to the injections. Mostly because the price tag goes up, as you go. But at some point, I suspect once those get up to where there are generics, the world will change on that. Here's the bad order of how they're used. So, to kind of summarize here. Duh. But we've talked about how complex all of this is, how much is going on, normally, let alone once you traumatize the central nervous system, particularly the brain. But what I hope I've at least communicated to some level is how interactive these conditions are. That we have to sort out, if we're seeing a symptom, where's it really coming from? Is it really just something more direct that we can just concretely say, aha, treat that, or is it because of something else going on over here? And that's unfortunately, there's no good clinical paradigm to zero in on that. It's just basically your best clinical assessment, implement a treatment, monitor, see if you get a result. If you don't, change. And I think I made it very clear that a lot of these medicines are used for multiple different conditions. And which I kind of like, on the other hand, it also says we don't have. So it's because we don't have something more specific. But at the end of the day, is that I'm relying on you guys as a treating physician. I'm sure my colleagues who prescribe these drugs would say the same thing. First get started, bring to me at the table what you're seeing clinically is problematic. It's interfering with their progress and goals, achievements. We talk about it, we do make our best assessment, implement something. Then I need to hear back from you. Are we getting anywhere? Yeah, or is something else emerging? Sometimes it's an onion effect where you peel off one layer and guess what? Find something else. So that is so essential. And it was obviously starting out as a therapist for as a doc. I mean, I've always been about interdisciplinary team and interaction. Sometimes it's easy. I'm over in an office over there. You guys are here, or you're working, and being able to have that communication is challenging. Although we now have so many more ways to utilize to make that So I really rely, like I said, very heavily on all of you.
Thank you.
Yes, Millie.
Just a question.
Yeah.
In your practice or in the literature, have you seen anything where they're using pain medications in conjunctions with something which, heard a lot lately from clients and patients, like hyperbarics?
Well, this is again, yeah, I mean, there's been a lot of interest over the years. Vertical spinal cord injury after traumatic. And at least the clinical trials that I know about are older. I mean, I don't know if there's going to be recent or revisited. Didn't show a very robust response at all. And I think people have been reticent to go back and try to restudy it because if you're in academics, you're trying to publish things that actually make a difference. Not, I mean, promotion, it's not all about just altruistic, I want to change the world. It's about, if you want tenure, you better publish in something that's meaningful. Publishing negative studies all the time, it's garbage. They're going to just say, well, sorry, we'll find another job.
Yeah, thanks, grab at it.
Well, and bless them, if I were dealing with what they're dealing with, I certainly would be grasping. And my job, I feel hard is just to be honest. And you know, one of the rules of thumb that I have, and it actually comes from, in part, my affiliation with Walk the Line for many years, is if there are not data to support doing something, number one, is there at least a theoretical basis that it makes sense to try it? Number two, are the risks low? I mean, if those two things pass muster, then we can at least talk about it. But so I mean that's just a starting point. I mean, if you can't get past those two, thank you.
Thank you.
Mhm.
One last thing to add.
Yeah.
I noticed in the seizure medication, put those, medications, I think that much.
That's more used in pediatrics, and I'm not sure. I mean, sedating is one of the reasons, and I'm not sure why that was so favorable in children, except that used to be Dilantin. It was just Dilantin and phenobarbital, and they didn't want to give kids the Dilantin because of some of the effects on a growing child. But now we have more options. And I haven't paid attention in recent years to children with TBI and that need to be prophylaxed what they are receiving these days.
Charlotte says she sees Gideon in pediatrics.
Okay. Fair enough. Thank you, Charlotte. All right. Jackie.
Doctor, what do you do for a pain right here?
The area she touched was her neck.
No,
When it's case managers, it's a pain here.
No, I was just gonna say with, when you prescribe a beta blocker, sometimes we have to explain to these adjusters
I understand.
because they give us such a, that is a blood pressure pill.
I know.
No, they use it for other things, so it's,
And I mean, we're always going to
yeah.
is, you hope at some point there's a learning. But
I know.
one of the problems, first of all, is adjusters are involved or they change frequently.
Yeah.
So you get somebody new who hasn't been involved with something like this, they just don't have any background or experience.
Mhm.
Second is that, put it crudely, insurance companies are in the business of collecting premiums, not paying claims. So they're going to challenge stuff just to challenge stuff.
Yeah. So much fun to educate them all.
No, it is. Well, one of the best, totally irrelevant to this is there's clear data in people who have had a spinal cord injury long-term, they're much higher risk for cardiovascular disease. So I had a guy who was 30 years out, he was in his 60s, and cardiac death, and sure enough, he did damage. Well, this is auto-related.
Right.
So I pulled out half a dozen papers, and I sent it to his adjuster supervisor, because the adjuster sent me an answer, because I didn't know what the hell I was talking about. Surgery got paid for.
Thank you.
You're welcome. Thank you.
Very cool.
I said that really quick.
All right, thank you everyone for attending. I'll make sure that I can get you the slides and information. Please make sure you fill out the post evaluation questionnaire and that you signed in so that way you guys can receive your credits. If I go here.